Ladies and gentlemen, we'd like to continue. Please take a seat. We will have a very interesting last session, and Patrick Serrois will introduce the second part of the speakers and moderate the discussion. And the question is, where are our patients for LAA closure? And we'll have 4 groups of potential patients presented, and we'll have 4 eminent speakers defending one of these groups. Now, I know there are other groups that you could put your money on, like renal insufficiency and so forth, but you have to cast your vote now. If we can have the polling system up, you have to cast your vote on one of those 4 potential groups of patients that can be recruited for LAA closure. We'll see the share of each group, and after the speakers have defended their group, we'll do it again, and we'll see how much share they've won or lost, how well they have defended their recruitment group. So it's pulmonary vein isolation, LAA occlusion, so the electrophysiologist who combines the 2 things concomitantly or deferred, ischemic stroke on NOACs, so patients who were anticoagulated but broke through, GI bleedings, the bleeders in general, but of course GI bleeding is the most common bleeding, and then the patient who just doesn't want to take anticoagulation. So casting your vote will remember then the percentage that each group you have to put your vote on that group that you think is the most important group for your own practice. I will then look at the vote before we go to the speakers. I will give you some hints, some groups of patients that are not among those 4 that I think we should not forget. Some of them have been mentioned. So it's a pretty equal task, equal outcome. Okay, almost a quart, but the bleeders, GI bleeders win. So let's see how well those people do with defending or improving their percentage, their share that they have. If you can come back to my slides. So, of course, oral anticoagulation, maybe a little less so now with NOACs than it was with vitamin K antagonists, is a tightrope walk. And the bad thing about it is not only that you fall off, if you anticoagulate too much, you fall off. If you do not anticoagulate enough, you fall off, either with stroke or with bleeding. The bad thing about this, it goes on forever, forever, forever. It's a never-ending story. You have to continue that. And the risk is ever there and is ever increasing. And then, of course, are those 13% of patients, these that are our candidates that everybody agrees cannot take oral anticoagulation and cannot take NOACs. So these are our customers for sure. Then, John Cam has also mentioned that are all the patients, with a high grade of Jets-VAS score who should get anticoagulation but just don't. And the risk factors that increase the Jets-VAS score kind of deter us from putting them on oral anticoagulation because we think they're risky is not what makes our intervention more difficult. So we can close LAAs even in people with high Jets-VAS score. Then, of course, one thing is the underweight patients. Just a recent paper showing that NOACs used in underweight patients has a significantly higher rate of bleeding than what we know from NOACs from the overall trial. So that's one of the groups that we can as easily or close the LAA if they're underweight or not underweight. But if they take oral anticoagulation every year in their life, they have an increased risk of bleeding. Finally, again, I get tautologous about what John Cam said, but I do that on purpose. People just don't take oral anticoagulation drugs. And we know NOACs also are stopped by patients. And an anticoagulation drug is the drug that is stopped most compared to statins, platelet inhibitors, and antihypertensive drug. The first drug people stop for whatever reason is the oral anticoagulation. Finally, we've done very good, with improving oral anticoagulation for preventing stroke in atrial fibrillation from doing nothing. We came down, particularly with the NOACs, to a very impressive reduction of the stroke risk. But even now with the best data that we have, in large study, there's still a 24% of our risk is remaining. So I can make a case for combining the belt and braces type of approach. Why not combining some kind of oral anticoagulation with LAA closure? So keep that in mind also. Then, of course, we've also talked about that if you have to combine anticoagulation, antiplatelets with oral anticoagulation, the bleeding risk actually gets outrageous. So that really is something we have to worry about. And we have some data here where we replaced in patients who had atrial fibrillation and got coronary stents. We replaced the triple anticoagulation scheme by just antiplatelets plus LAA closure. And you see, we almost got an outcome comparable to patients who did not have atrial fibrillation, just had stents, and there was never a question of triple anticoagulation. So LAA plus just the normal stent treatment seems to be better than triple anticoagulation. Finally, the excellent paper that Jens Erik has shown already today, where now in patients with an Emplatzer device, the one that we're discussing here, and a prior intracranial hemorrhage. And why should that not also be true for any patient with atrial fibrillation, at least in the same trend, had a markedly reduced mortality if you look at whether they had the LAA closure or whether they had any type of anticoagulation. Of course, that's a mixture of antiplatelets, which are good for nothing, and oral anticoagulation. But even if you concentrate on just the patients who did have oral anticoagulations, and of course, NOACs were only in 1/3, and 2/3 were 3/4 were actually VKA, but still it seems to be that even compared to that, the mortality with LAA closure is improved. And Fabian Niedlisbach has taken the trouble, to put the outcome of the patients that had LAA closure, just project them here on this curve here of the event of stroke and systemic embolism during follow-up. And you see that these patients follow exactly the NOAC curve rather than the warfarin curve. So LAA closures in terms of stroke and embolism prevention, at least in this indirect comparison, seems to be competitive with NOACs and better than warfarin. And of course, that's only one side of the medal. If you look at the bleeding, you know that even with NOACs, there is a yearly risk of bleeding. And of course, we're following here the example of Jens Erik, and only use antiplatelets after LAA implantation and even stop it if there is no reason after a few months to continue on. And you see that the bleeding risk, annual bleeding risk, is significantly smaller, and that goes on and on and on. And finally, you probably see this very important paper where they looked at how the Watchman device, in this case based on randomized data performed compared to the new anticoagulants in terms of a comparative effectiveness. And they looked at the mortality, so the least mortality is the most on the right, and the fewest strokes and bleedings is the highest up here. You see that Watchman actually had the lowest mortality of all these approaches and one of the lowest stroke rates. So it is very competitive with these new oral anticoagulants, of course, much better than VKA antagonists. And finally, and Fabian Niedlisbach showed such a case. Of course, this one-stop shop procedure is very good for the patient. This particular patient just spent one night at the hospital and during one intervention got a new valve, LAA closure, because he had bladder bleeding with atrial flutter, and also got a coronary repair. And of course, if he had atrial fibrillation, you could have also combined that with ablation, and Boris and Torsten will talk about that in a moment. I think if you're already there, and Fabian has shown that, if you're in Italy, buy the good wine while you're there. Same thing here. If you're already in the left atrium, why not combining ablation with left atrial appendage closure? We'll hear about that in a moment. Finally, a very provocative last slide. This is primary preventive LAA closure. What does that mean? Primary preventive LAA closure means you close the LAA in somebody who never had a bleeding and never had a stroke. So it's primary prevention of what you want to prevent. Primary prior means they never had atrial fibrillation either, and so you still close the LAA. Why would you do that? And we have a small series of those patients. You see this particular patient, 64 years of age, with 2 large ASDs. For some reason, although the atria were large, didn't fibrillate yet, but you're almost sure fibrillation is around the corner. Now, if you close those 2 ASDs, which can be done, of course, it will be very hard to get back into the LAA when atrial fibrillation starts. So why not going in with the LAA sheet, put the device in the LAA, and through the same sheet, this 14 French torque sheet is very good also to close the both ASDs on the way out. You see the left atrium, the right atrium. And you see the follow-up here in this particular patient with a nice result of the ASDs at a few months down the road, and of course also a nice result of the LA. Now, interestingly, this patient is now 5 years out. He still never has had atrial fibrillation, but someday he probably will. Okay, thank you. So I'd like to ask Torsten to come up here.